new diagnostic modality in ...
I thank Dr. Oni for this opportunity, and thank you for those blanks, so now I can just speak about whatever I feel like. Basically, I would be talking about things which haven't been covered in like non-AMD areas, where specifically where I found Octa to be invaluable and really, really useful for managing my patients. So the outline of my talk is we'll start with macular pathology, we'll go deeper, we'll see what has never been seen, then we'll go wider and we'll see what has never been seen without a dye in the past. And these are the two areas I'd like to cover. So here you can see basically this is again anatomy, and the retinal capillary system in the macular area is consisting of the superficial, intermediate and the deep. And what's very interesting is it's only the superficial which is seen with fluorescein angiography. The other two plexes are invisible with FFA. I think we are very hungry this morning, so this is the second cake to come up in the session after Dr. Uni's chocolate cake. So we have a vanilla cake here. So if you just look at in fact, I'm going to say opposite of what Dr. Uni said. If you just look at the cake, it looks like it's a plain white vanilla cake. But look at the colorful layers within, and this is what Octa is going to help us do. Layer by layer, we're going to go segment and see what lies within. My first case is a patient who's been challenging me since 2012, for last 8 years. He's a retired brigadier. Came for a routine checkup, non-diabetic or hypertensive. He has a history of porphyria. And left eye, he says the vision has been poor for 4 years. He's known to have had CSR in the past, vision 618. He is not interested in any further treatment. So we said, okay, you can come for after 6 months. And lo and behold, again, he's come after 3 years in 2015. And please see the blue colored arrows which are there on both sides. Look at the SRF which has come up in this patient in both the eyes. Vision in left eye has dropped a little bit, and you see little pockets of fluid here. So just to make it simpler, 2012 is below and 2015 is top, and you can see the fluid coming up. And look at the interesting configuration of the RP also, the irregular PED. Unfortunately, we did not have Heidelberg at that time, so we just have the flash imaging, the FFA and the ICG, and we could kind of imagine some fuzzy small CNVM in this eye, and we gave 3 anti-VEGF injections at monthly intervals. Patient is not happy, this is after anti-VEGF, the fluid is just not going away. So now we are worried about our diagnosis. Are we diagnosing it correctly? Is there any component of CNV in this patient or not? And this is where the initial Octa came in and rescued us. So now on the Octa, we can see these vascular loops in the right and the left eye. Also, we went deeper with swept source imaging and found how thick the choroid was, 500 microns in this patient. We did a wide field autofluorescence, and we could see the vascular tracts confirming the kind of combination this patient was suffering from, CSR, CNVM. So that time aflibercept was introduced, and lo and behold, you can just see, I've just put one scan because we don't have time to show you all, but one aflibercept, and you can see how beautifully the edema is resolved in the upper scans on both the sides. And now, of course, we have swept source Octa, and you can see beautifully the capillary loops in both the eyes. And now this patient has to have aflibercept every 3 to 4 months, and I'm titrating his treatment based, of course, on cystoid changes, SRF, but also on the vascular network at times. So the learning points from this case is there can be a type 1 CNVM lurking in the case with sick RP in pachychoroid. PDT would be ideal for such a patient, but because he has porphyria, it can be fatal, so I don't have the guts to do PDT in this patient. And Octa cleared the doubts about the presence of CNVM, and it justifies using an expensive treatment in this patient. Let's move on. PAM has already been discussed right now, just before me, and you can see the beautiful PAM lesion in the structural OCT. But I want to concentrate on the center figure in the middle, and you can see how the superficial layer is fine, but you can see how affected the deep layer is in the Octa, and this is seen only on Octa. Next, we will talk a little bit about best vitelliform. I would like to run the video. So you can just please look at the upper part, the upper video in the black, and you can see slowly. So sometimes vitelliform just gives a kind of hyperfluorescence on FFA. You don't know whether the CNVM is there or not. But keep looking at that image. See how beautifully the network lights up. And there's no doubt that this patient needs therapy. There's no doubt that at hyperfluorescence, the fuzziness which you see on convention, it is something which is lying beneath, which you need to treat. Unnecessarily, we should not be giving these patients anti-VEGF, but this is one case which does require anti-VEGF and does well with it. MacTel, I think, has been extensively discussed this morning. So now just a quick word. This is the Gas and Brody classical teaching, the classification. There's a more detailed and a very busy slide showing the latest OCTA classification. But basically, it starts off with a normal network where we only see telangiectasia in the temporal part of the fovea, in the deep plexus, and it goes on to the stages which have CNV. So here, this is one of our patients. So you can see, basically, it looks normal in the superficial, but here you see telangiectasia seen on the temporal part in the deep plexus. As you go more towards the complex cases, you see some telangiectasia in the deep on all around the fovea. And as it goes to grade 3, the pigment accumulates and shows vascular invasion. And most important is grade 4, or the one where the CNVM, and of course in this it's very important to see the avascular segment, and this is where scrolling the scan is important, because only when you scroll the scan you'll be able to actually delineate that you have a network in a place it shouldn't be, and this is the only stage which would require therapy. So now that we have gone deeper, let's move on. Let's talk about how we use it for wide field imaging. So it's excellent to use Octa for patients, of course, with deranged kidney function, but even if the kidney function is not deranged, it is nice to use it as a non-invasive modality, which we can repeat it again and again. We don't want to keep on injecting our patients with dye. So with a high resolution wide field imaging, we are able to get scans up to, with swept source up to 22 into 22 millimeters, and these are some of our patients. So this is the conventional imaging. You can see a proliferative, it's a spotter, diabetic retinopathy, and see how beautifully you can see the network, the peripheral capillary non-perfusion with the montage on the Octa, which is done with swept source imaging. Let us see whether we can titrate our therapy also according to this. So this was a case of proliferative diabetic retinopathy. You can see the beautiful NVE. And the first two, if you really, these two are Octa, and the third is conventional angiography. And post-laser, you can see how the leakage is gone and how the network has vanished in the figure below. And this is a corresponding structural OCT below. And what I would like to bring out is, this was something we published as a photo essay in IGO, but you can see how nicely the flow, the red dots are there pre-laser, and the FVP has shrunken, become thinner, and shriveled up, so to say, post-therapy. Again, NVE regressing. So this is a patient with neovascularization just nasal to the optic disc, and this is a color photo, and this is of course not angio, this is an Octa. And you can see 3 days after anti-VEGF how it's resolved beautifully. And although the thick vessels remain, most of the thin networks are gone after anti-VEGF. So to conclude, whenever we see Octa, it looks very impressive and beautiful, but there are some tips for interpreting it. Otherwise, we're going to make a lot of mistakes, and we're going to see a lot of things which are not actually there. So just firstly, please analyze layer by layer. So that's very important. Secondly, correlate it to the B scan with the UNFAS scans, because if we just see it in isolation, we're going to make mistakes. And third is analyzing the video can help, because sometimes if you just get a printout from your optometrist or the person who's sending it, you can miss a lot of stuff. So you have to see the video or do the scrolling yourself. So this takes time. So what we always say is FFA, you say it takes 5 to 10 minutes or whatever, but interpreting, now we are used to it, we can interpret in a few seconds. But with Octa, it's the other way around. The scan takes a few seconds, but we take several minutes to kind of interpret it. So I think that's a challenge in a busy OPD. So I'd like to acknowledge my co-authors and thank you for this opportunity.
Thank you, Daraius. I mean, just to start off the discussion, which all clinical scenarios would you say this is the only modality I need?
So I don't think, of course, as I think Dr. Storingi always says, proponent of multimodal imaging. So I think multimodal is important. But I would say that, for example, in a case of BEST, for example, BEST vitelliform, if we are suspecting a CNVM, not showing it. I think, so certain cases like that, I think it really has helped us. And also, many of these type 1 CNVMs in cases of CSR, the elderly patients CSR. So these are two things where I find it very, very useful.
And how do you use it in myopic CNVMs?
So that's very interesting, because I think the next session here I'm going to be presenting exactly what you asked in Dr. Anirudh Agarwal's session. So basically, in myopic CNVMs, I would really be scared to make a diagnosis only on Octa or this thing, basically because you can definitely miss it. So I think FFS still has a role in myopic CNVM, but the way Octa is useful, and also the structural OCT, what I like to see is if the fuzziness and the thickness of the retina overlying that CNVM. So these are clues about how the membrane is responding. So are you interested in the response to therapy or the diagnosis? What was your question in your mind?
Both.
Both. So I think initially maybe what we do is for the initial diagnosis, we do multimodal imaging, but for response to therapy, then you can rely on the non-invasive.
Thank you. Do we have any questions, please?